Hypokalemia is one of the most common water-electrolyte imbalances and affects about 20% of patients admitted to the hospital medical surgical services and about 40% of patients admitted to intensive care units. The most common causes of hypokalemia, defined as a level below 3.5 milliequivalents per liter, include vomiting, diarrhea, hypomagnesemia, diuretics such as furosemide, hyperaldosteronism, and less commonly inadequate intake. Normal potassium levels are between 3.5 and 5.0 milliequivalents per liter. Mildly low potassium levels, around 3 to 3.5 milliequivalents per liter, typically do not cause symptoms. However, they may increase blood pressure and provoke the development of an abnormal heart rhythm. Moderate hypokalemia, with serum potassium levels of 2.5 to 3 milliequivalents per liter, may cause muscle weakness, tiredness, myalgia, tremors, muscle cramps, and constipation. Severe deficits leading to serum potassium levels below 2.5 milliequivalents per liter may be life-threatening and lead to electrocardiographic changes such as QRS prolongation, ST segment and T-wave depression, and U-wave formation. The earliest ECG findings in patients with hypokalemia are decreased T-wave height, followed by ST depressions and T inversions as levels continue to fall. Calculating deficits involves the potassium deficit equation. K deficit in mol equals K normal lower limit minus K measured, times body weight in kilograms, times 0.4. The size of the deficit is difficult to determine because only 2% of the body's potassium is present in the extracellular fluid. In addition to the total body potassium stores, many factors contribute to the serum K+ concentration, so it is possible to underestimate or overestimate the actual deficit. This equation also does not consider the daily losses and requirements of potassium that are needed in addition to the deficit. The kidneys are responsible for about 90% of daily potassium loss, approximately 40 to 90 milliequivalents per day. The kidneys have only a limited ability to conserve potassium. With little to no intake of potassium, the urine will still contain at least 5 to 20 milliequivalents of potassium per 24 hours. Hypomagnesemia often accompanies hypokalemia. Hypokalemic individuals not responding to potassium therapy may be refractory to treatment until hypomagnesemia is corrected. When evaluating hypokalemia, the clinician should determine whether the hypokalemia is a result of low intake, increased cellular uptake of potassium, or excessive loss of potassium via the kidneys, GI tract, or skin. Inadequate intake rarely is the sole cause of potassium depletion unless inappropriate and continued renal or extrarenal losses occur, or potassium intake is severely restricted to less than 10 to 15 milliequivalents per day. The urinary potassium concentration is a good marker for differentiating various hypokalemic syndromes. A urinary potassium excretion of less than 20 milliequivalents daily suggests extrarenal potassium loss. The amount of potassium deficit and the rate of continued potassium loss should be determined to guide replacement therapy. It has been estimated that a 1 milliequivalent per liter fall in serum potassium from 4 to 3 milliequivalents per liter represents a total body deficit of approximately 200 milliequivalents. When the serum potassium falls to less than 3 milliequivalents per liter, the total body deficit increases by 200 to 400 milliequivalents for each 1 milliequivalent per liter reduction in serum concentration. Other data suggest that even greater degrees of potassium loss can occur, with a deficit of 100 milliequivalents per 0.27 milliequivalents per liter fall in the serum potassium concentration. Transcellular redistribution of potassium may significantly alter the relationship between serum concentration and total body deficit. Potassium repletion should be guided by close monitoring of serum concentrations and urine analysis for potassium content to help assess the need for additional replacement. The route of potassium administration depends on the acuity and severity of hypokalemia, but oral supplementation is usually preferred. The parenteral route is indicated for patients who cannot tolerate high dosages of oral potassium supplements and for those with severe or symptomatic hypokalemia. Aggressive therapy is not warranted in patients exhibiting mild to moderate symptoms of hypokalemia.